Good afternoon. My name is Janice Whitaker, and I'm the CGNE Administrator and Community Liaison, and it's my pleasure to serve as host of the CGNE Seminar Series. This program is being provided by the Tressa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Outreach and Professional Development Office, the Center for Nursing Research, and Age-Friendly Care PA. Today's seminar is entitled Factors Associated with Sleep Quality in Hospitalized Persons with Dementia, and it will be presented by our first ever CGNE postdoctoral scholar, Dr. Ashley Kuzmik. We've been fortunate that Ashley is an integral part of our center, and we look forward to hearing about her work on this important topic to improve care for older adults living with dementia. Before this informative session begins, there are some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire Nursing Continuing Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we do not identify, mitigate, or disclose relevant financial relationships. In order to earn contact hours, Zoom in and out times will be recorded, and the post-event evaluation survey must be completed. This seminar is being recorded, and if you have questions or comments for our presenter, you may enter them into the chat, or you can raise your hand during the discussion portion of this seminar, and we will unmute you and encourage you to share your comments or questions aloud. The post-event evaluation survey link will be placed into the chat and emailed you as well within 24 hours. We do require that RNs and other participants complete this within a week. And we will pause after the presentation to allow an opportunity for people to complete it during the seminar if you have that time to do that. The certificates for the Nursing Continuing Professional Development will be emailed to registered nurses within a month of the seminar. And if you have questions about any of that information, please reach out to us at cgne@psu.edu. Next, I'd like to introduce Nahida Akhter, who is a CGNE graduate student affiliate. She's currently enrolled in our PhD program with a focus on person-centered care for older adults. Thank you for introducing our speaker today, Nahida.
Thank you so much, Denise. So good afternoon, everyone. Dr. Ashley Kuzmik is a postdoctoral scholar at the Tressa Neese and Helen Diskovich Center of Geriatric Nursing Excellence in the Penn State Ross and Carol Neese College of Nursing. Ashley has a Master of Public Health in Epidemiology from the University of Cincinnati, and she recently completed her Doctor of Public Health in Epidemiology from Penn State University College of Medicine. She has presented her research at local, national, and international conferences. Building on her dissertation research that examines the interaction between social factors and physical activity among adults, Ashley is further exploring physical function in older adults with dementia.
Thank you so much for the introduction, Nahida, and good afternoon, everybody. I'm thrilled for the opportunity to present at this week's CGNE seminar. And today I will share with you an exciting study that I conducted in exploring factors associated with sleep quality in hospitalized persons with dementia. This study has been accepted for publication in Alzheimer's Disease and Associated Disorders Journal. It is not out yet, but will be available to the public in the very near future. To start, I will discuss the background for the study regarding sleep in patients with dementia. This topic is very important since up to half of persons living with dementia experience problems with sleeping, which can cause increased distress for the individual as well as their care partner. So to further explore sleep in persons with dementia, I will provide a general introduction to sleep, sleep quality in persons living with dementia, and sleep disturbance in the hospital setting, and then I will follow up with the study findings. As we know, sleep is a basic human need, and it's necessary for optimal health and well-being. And adequate sleep is essential for physical performance, cognitive functioning, and emotional regulation. Sleep is necessary to learn, pay attention, create new memories, make decisions, be creative, and solve problems. And poor sleep quality is associated with higher risks for high blood pressure, obesity, heart disease, depression, and Alzheimer's disease. And lack of quality of sleep can result in worsened memory, poor mood, stress on relationships, and increased risk of falls or accidents. So you might be wondering how we can define sleep and how is sleep quality measured. So to do this, we can ask 4 questions about sleep quality. And these are, can I get to sleep easily, which measures sleep latency? Do I wake up frequently, which measures sleep fragmentation? Do I get enough sleep, measuring sleep duration? And is my sleep efficient, measuring sleep efficiency? Sleep is critical at really any age, but the recommendations can vary among different groups of people or individuals. And the average older adult requires 7 to 9 hours of sleep per night. But the important questions to ask is, how do they feel? Are they well rested? Sleep quality is associated with a range of factors among persons living with dementia, including physical and mental health and psychological symptoms and behaviors. And factors associated with poor sleep quality in older adults with dementia include increased behavioral and psychological symptoms of distress, BPSD, delirium, depression, and pain. It's also been found that demographic characteristics like age, gender, race, ethnicity, and education levels have also been associated with poor sleep quality in older adults with dementia. Other factors like underlying medical conditions like pulmonary disease or congestive heart failure, comorbidities, levels of cognition, and medications can also contribute to sleep disturbances. Prior work has found that older adults with dementia may experience sleep pattern changes, such as frequent and longer awakenings at night, trouble falling asleep, and decreased sleep duration. And these sleep pattern changes can cause restlessness and disorientation with time, such as getting up early during hours during the night, or thinking it's daytime, or going to work, thinking it's time to go to work. So persons living with dementia may experience reversal of sleep-wake cycle and experience daytime sleepiness and napping as well. It's been found that hospitalized older adults are at increased risk of poor sleep quality. Sleep quality is negatively impacted in the hospital, and hospitalized persons with dementia are particularly vulnerable to sleep disturbances. And the prevalence of sleep disturbance is up to 67% of patients with Alzheimer's disease, and sleep disturbance has also been reported in up to 90% of patients with other dementias like vascular and Lewy body dementia. Sleep disturbance during hospitalization increases care dependency and hinders rehabilitation, which increases the risk of fall-related injuries, functional impairment, institutionalization, and early mortality. In the hospital setting, environmental factors like the noise or light exposure, medical procedures like getting your blood drawn, arousing patients for late evening or early morning for medications, and patient-related factors like pain or medical conditions all can cause sleep disturbance in the hospital setting. For example, health conditions like frequent need to urinate, asthma, diabetes, osteoporosis, nighttime heartburn can interfere with sleep. Also, sleep disorders like restless leg syndrome, restless eye movement, and sleep apnea may also contribute to sleep disturbance. Although some causes of sleep disturbance are known in the hospital setting, factors associated with sleep quality have not been well examined in hospitalized older persons with dementia, and this particular population is at high risk for impaired sleep in the hospital setting. So this study aimed to identify factors associated with sleep quality among hospitalized persons with dementia. And we hypothesized that delirium severity, pain, depression, BPSD, and daytime physical activity would be associated with sleep quality characteristics like sleep duration, sleep efficiency, sleep latency, and sleep fragmentation among hospitalized persons with dementia. For this study, we used baseline data from a cluster randomized control trial that tests the efficacy of a family-centered function-focused care, family-centered FAMFFC, which is a family nurse partnership focused on improving functional outcomes related to hospitalization. The FAMFFC intervention incorporates 4 components that are implemented by a nurse interventionist and selected unit-based champions, and we have 2 per unit. The FAMFFC includes a FAMPath, which is a family care partner and patient education on preventing hospital-acquired complications. And the FAMPath is engagement of family care partner in patient and goal setting, implementation, and evaluation with post-acute follow-up. Additionally, components include the environmental policy assessment, which modifies to promote safe mobility and function, staff education and training, which is function-focused care and engagement of family, and also mentoring staff and the champions. The aims of the family function-focused care study are to validate the efficacy on patient outcomes that include physical function, so activities of daily living, performance, and physical activity, delirium occurrence and severity, NPS, and mood like depression. It also aims to evaluate the impact on family caregiver-centered outcomes. So that includes family preparedness for caregiving, strain, burden, and desire to institutionalize. Also calculating the costs, so evaluating relative healthcare costs and total cost savings for the intervention FAMFFC versus the control condition. And the other aim of the parent study is to evaluate the cultural appropriateness for diverse families in our sample. For this specific study, this was a descriptive cross-sectional study. It was conducted in 6 medical units in 3 hospitals in Pennsylvania. And our sample included 259 hospitalized persons with dementia. Patients in this study were included if they were at least 65 years of age and older. They spoke English or Spanish. They lived in the community. They screened positive for dementia using the MoCA with a score of less than or equal to 25 or a score of greater than or equal to 2 on the 88. Screened mild to moderate dementia using the clinical dementia rating scale. And they also needed to have a caregiver or care partner to be included in the study. The exclusion criteria for the study was if the patient had a major acute psych disorder, a significant neuro condition associated with cognitive impairment other than dementia, if they were receiving hospice care, or if they were admitted from a nursing home, we excluded them from the study, and they were also excluded if they experienced transfer to another unit for stays longer than 48 hours. And any known sleep disorders like sleep apnea or restless leg syndrome, we excluded the patients from the study. For this study, descriptive data included age, gender, race, ethnicity, education, marital status, the length of stay, comorbidities, and cognition. And comorbidity was evaluated using the Charlson Comorbidity Index. Our factors that we examined were delirium severity using the confusion assessment method short form, so the CAM-S, pain, measured by the Pain and Advanced Dementia Scale, the PAIN-AD, depression, which was measured by the Cornell Scale for Depression and Dementia, and behavioral and psychological symptoms of distress using the Brief Neuropsychiatric Inventory, the NPI, and then daytime physical activity. Our outcome measure was sleep quality, which evaluated sleep duration, sleep efficiency, sleep latency, and fragmentation. And our daytime physical activity and sleep quality characteristics were objectively measured using the Motion Watch 8. So the Motion Watch 8 is referred to as the next generation of actigraph, and it uses a triaxial accelerometer and has a built-in ambient light sensor and event marker that provides an option for long-term recording, so there's no interruptions for battery charging. It's typically worn on the wrist, which provides a close correlation to whole body movements to monitor physical activity and daily activities, and also sleep quality. Physical activity that's measured by the Motion Watch 8 is that data are sampled at 50 Hertz and processed into epochs of 1 minute. And the counts of the unit of measurement are used to evaluate activity, calculated as the number of times the waveform crosses 0 for each period being evaluated. And the outcome measures the sleep quality characteristics measured by the Motion Watch, included the sleep duration, defined as the total time spent sleeping, sleep efficiency, defined as the time asleep expressed as a percentage of the time in bed. Sleep latency is the time between lights out and falling asleep. And sleep fragmentation, measured as a percentage, was the total time spent sleeping, categorized as the sum of mobile time and immobile bouts. The advantages to wearing the Motion Watch 8 is that it's like wearing a watch, and it can evaluate movements during daily living and sleep. And it's been shown that it's reliable and a valid use in older adults with dementia in hospitalized settings. In another study, I tested the feasibility and validity of the Motion Watch 8 in hospitalized persons with dementia. And we found that about 81% were willing to wear the watch. And the results showed that the time in low activity and time in moderate activity measured by the Motion Watch were associated with the participant's physical function. And here's a picture of the Motion Watch 8 worn on the wrist. And it's typically comfortable for the patient, and patients actually want to wear the watch. For example, some patients that weren't enrolled in the study made comments that they wanted to wear the watch too when they saw our research team put it on the patient who was enrolled in our study. So a little bit of jealousy about the Motion Watch. And to upload the Motion Watch data for each participant, we use REDCap, which is a HIPAA protected database that secures our study data. So in REDCap, we have an option to upload the Motion Watch file here that's indicated by the red arrow. And when we want to analyze the data for each participant, we download the file from REDCap and open the file in the MotionWare software. And that allows us to gather sleep and activity levels for each specific patient. As far as data analysis, we use descriptive statistics to describe the sample of participants, and multiple stepwise linear regressions were used to investigate the potential predictors associated with each sleep quality outcome. So the sleep duration, efficiency, latency, and fragmentation. All models were adjusted for age, gender, race, ethnicity, education, cognition, and comorbidities. The 259 patients had a mean age of 81, and they indicated significant cognitive impairment indicated by the MoCA with a score of about 10.73. The majority of patients in our sample were female, 60%, and they were either non-Hispanic Black, 47.9%, or non-Hispanic White, which was 49.8%. Majority of the sample were married, 32%, and 50% were high school graduates. On average, the Charlson Comorbidity Index score was 3.8, and the average length of stay for the patients in the hospital was about 6.4 days. The patients indicated poor sleep quality with short sleep duration, about 312 minutes, low sleep efficiency, 65%, prolonged sleep latency, about 38 minutes, and high sleep fragmentation with an average of 58.3%. In our sample, most of the patients had low levels of delirium severity with a CAM-S score of 1.3. They reported slight BPSD with an NPI score of about 8.8. And our sample really reported no pain based on the pain AD score of 0.72. And our sample had slight depression with a score of 9.9 on the Cornell scale for dementia or depression. And the daytime physical activity counts had an average of 36.93. After controlling for age, gender, race, ethnicity, education, cognition, and comorbidities, the multiple stepwise linear regressions revealed that higher daytime physical activity was associated with higher sleep duration and sleep efficiency, and then lower sleep fragmentation. And we also found that higher BPSD was significantly associated with prolonged sleep latency. We used a significance level of a value less than 0.05, which is indicated here by the p-value column. These are small sample variances, and we are interpreting these as a signal that they are meaningful contributions, and we still need to consider other factors as well in future studies. Our findings partially supported our hypothesis. We found that higher levels of daytime physical activity were significantly associated with increased sleep duration, improved sleep efficiency, and decreased sleep fragmentation, but not sleep latency. And greater BPSD severity was significantly associated with prolonged sleep latency. Surprisingly, we didn't find any significant associations between delirium severity, pain, depression, and sleep quality. And this could be due to the low levels of delirium severity, pain, and depression that were found in our sample. The findings align with our previous research showing that physical activity in hospitalized persons, including those living with dementia, improves outcomes like better activities in daily living function, better mobility, less delirium incidence and severity, and less hospital readmissions. And this study adds to this work with objective data showing a relationship between physical activity and sleep. This is very preliminary work, and our study had some limitations. So this was a secondary analysis that was based on a population that only included patients from one state, Pennsylvania, and 3 hospitals, which limits the generalizability of this study. Also, only medical patients with mild to moderate dementia were included, and the study did not examine other variables that could interfere with sleep disturbance, including medical acuity, medical type of diagnoses, types of medications, any active medical conditions the patient could have, and mental health issues. We also didn't examine other common sleep disorders that could disturb sleep quality in patients with dementia, like insomnia, periodic limb movement disorder, obstructive sleep apnea, and rapid eye movement sleep behavior disorder. This study did not measure self-reported sleep quality, and we rather used the objective measures of sleep characteristics, measuring the latency, fragmentation, efficiency, and duration by the Motion Watch 8. So future studies could include a measure to capture the subjective aspects of sleep, and that could be used using a measure called the Pittsburgh Sleep Quality Index. And this study didn't examine environmental factors upon sleep. And these are some things that should be considered for future work. So specifically, future work on sleep quality among hospitalized persons living with dementia can include assessing environmental factors upon sleep, like the noise levels in the patient's room and hallways in the hospital environment that maybe could disrupt sleep, temperature, too hot or too cold, disturbing sleep in the hospital environment, and also like other social factors, so interactions with other patients, staff interactions, or family interactions that could potentially be further examined with sleep and patients in dementia in the hospital setting. Moving on to implications of this study, the results suggest the need to encourage daytime physical activity and to increase physical activity in the hospital setting. Hospital staff can encourage things like early mobility, meals out of bed, encouraging the use of the toilet, sit to stand exercise, encouraging patients in bathing and hygiene, and also including the family care partner in the goal setting, planning, and intervention to encourage physical activity. Further, our results suggest the need to reduce or manage BPSD to improve sleep quality among hospitalized persons living with dementia. And this can include monitoring delirium status, so occurrence of delirium, the severity of delirium. And in addition to physical activity, attention to sensory needs like the use of hearing amplifiers, encouraging the family to visit, voice recordings from the family that's not present, and diversional activities. In conclusion, our findings showed that daytime physical activity may improve sleep duration, sleep efficiency, and sleep fragmentation, but not sleep latency in hospitalized older persons with dementia. Future research is recommended to examine the associations of daytime physical activity, including the type and intensity of physical activity and sleep quality in hospitalized persons with dementia. Also, greater BPSD severity may prolong sleep latency, which is the ability to get sleep. And future studies should further extend this work by examining types of BPSD and sleep quality. So measuring specifically like hallucinations, agitation, or appetite that could maybe affect sleep in the hospital setting. And the results suggest the need to encourage daytime physical activity and reduce and manage BPSD to improve sleep quality among hospitalized persons living with dementia. And overall, future research is warranted to examine the associations of daytime physical activity, BPSD, and sleep quality in persons with varying medical acuity and diagnoses in diverse settings. This concludes my presentation, and although there is still much more work to be done on sleep and quality of sleep of patients living with dementia, I believe this study contributes some important factors about sleep quality that can help healthcare professionals, patients, and patients with dementia and their care partners in the hospital setting. I'm looking forward to any questions, and thank you.
And thank you, Ashley. That was an outstanding presentation. And I think I agree with you that that is a very important study with a lot of really important information and excellent clinical implications. And Donna Fick wrote in the chat, excellent program of research. And I think those of us that participated in this seminar today would agree with that. Before we take questions and engage in conversation with Ashley, we do invite participants to complete the evaluation tool for the seminar. So this spring, we've tried a new strategy to encourage completion of the evaluation tool and to give you an opportunity to do that. So we're going to take a little pause in the program. Jenny has put the link to the evaluation tool in the chat. As a reminder, this evaluation is required for RNs seeking 1 contact hour, but we do appreciate that everyone participating in the seminar complete the evaluation in order to give us some important feedback about our programming. As a reminder, please rejoin the seminar after you've completed the evaluation, as your participation for the full seminar is required for contact hours. But you can also enter questions and comments into the chat while you're waiting for us to return. So we're going to take a little pause and we'll be back in just a couple moments. Okay, if you're still finishing the evaluation tool, by all means, please take the time to complete that now. or you can save the link and complete it after the seminar or whenever it's good for you. As a reminder, it does need to be completed within 1 week of the seminar. And if you have any questions, you can always reach out to us. So just looking at the chat. Looks like there might have been someone that had raised their hand, Jenny. So. Yeah. I'm not hearing your microphone, Jenny.
Cindy Keith is unmuted. If you
Yeah.
want to ask a question, Cindy.
Thank you so much. Okay, I did join a few minutes late. I apologize for that. Was the data, and you might have answered this in the beginning, the data that you collected, was it all from the device only, or did you have nursing staff or other people doing checks on these people, you know, eyes on kind of thing?
The sleep quality and the daytime physical activity, those were all objectively collected from the device. But we did, and then as far as the other factors like pain, depression, and our predictors, those were based on observation or report from the caregiver.
Okay, thank you.
Ashley, I thought you did a great job kind of setting the foundation for understanding by reminding us how important sleep quality is as a human being to overall well-being. And you also shared a lot about the barriers to getting adequate sleep when someone is hospitalized, but then expanded on that for persons living with dementia and their particular specialized needs. Can you, one of the things that you mentioned as you described the study at the beginning were some of the exclusion criteria. I was curious about why residents from nursing homes or long-term care settings were not included in this study. What was the thinking around that?
Sure, that's a good question. So this study was actually part of a larger parent study, so the Family Function Focused Care Study. And so part of the exclusion criteria for the parent study is we didn't recruit patients from nursing homes enrolled in the study. And we were primarily focused on community dwelling patients living with dementia.
Thank you. I understand that better now. Thanks so much. I was also curious, you mentioned that I think it was 80%, 81% of the patients were willing to wear the MW8 band, the device. What kinds of, so there was a few that chose not to, and I was curious as to what some of the barriers were to wearing it. And did you also experience any persons living with dementia that, you know, had attempted to remove the device? Did you run into any of those issues at all?
Yeah, that's also a good question. So as far as the feasibility of the motion watch, and yeah, like majority like to wear it and we're comfortable with it, but reasons for not wanting to wear it was some just like logistic and scheduling. So if they had like an early test or examination, like we didn't put the watch on and the risk of losing it. And also if like the family may have not felt comfortable, the patient wearing the watch, if they were more agitated and a risk of losing it, the parents or the families actually wanted us not to put it on to protect the watch so it doesn't get removed and or lost. And what was the other? There was a second part to the question.
Well, I think the families expressed some concern about their loved one potentially removing the watch. Were any of the patients living with dementia trying to remove it? Did you have that experience?
Yeah, sometimes they like if they were more agitated, not because of the watch, but just physically or the environment, you know, they would pull things. And so the watch would be one of the things that they would pull off. It doesn't really happen often, but, you know, in our study, validity and feasibility study, that was a couple of reasons why.
Yeah, and I know that, you know, when we used, you know, safety devices that looked like a watch or were on the wrist, that sometimes was caused some discomfort or distress for the person living with dementia. So I was curious about that. Cindy mentions in the chat, very interesting study. Thank you for sharing.
So we actually have 3 hands raised right now.
Oh,
So
good. Okay.
I believe Irene is first. So let me.
All right.
Hi, Ashley. This is Irene. Ashley, this is a great presentation. I'm really enjoying it very much. I think you really did a great job summarizing a lot of our work, and I did get the opportunity to work with Ashley on this family-centered function-focused care study as a nurse interventionist. So I just wanted to say that the data does really reflect a lot of kind of the information I was seeing observationally. And it does make me, you know, curious about, in particular, how fragmented our patients' sleep is. That number is just so striking at 58%. And just the small chunks of sleep, you know, it sounds like with that average duration of 312 minutes. So I would say that is consistent with a lot of what I have observed in the hospital setting. And it makes me think about how much of those sleep interruptions are actually caused by, you know, the staff causing the interruption versus something that the patient needed, such as, you know, a need to use the toilet in the middle of the night or something like that, that might interrupt sleep. So I just thought that that was really well presented and gives us, you know, food for thought about how our care practices actually can sometimes be problematic in terms of interrupting our patients' sleep. Thanks, Ashley.
Thanks so much, Irene. Irene's wonderful. Pleasure to work with her. And yeah, that was great feedback and something that we could look forward to in future work.
Your presentation kind of reminded me of my early days as a registered nurse working in acute care, Ashley, and how I always felt like one of my priorities working night shift was to promote sleep. And it can be challenging depending on, you know, the doctor's orders, the different care plan interventions that need to be accomplished. But I think you've given us a lot of things to think about, you know, trying to organize tasks in a way that reduce the number of times you're entering a patient's room. I know there were even times where I went into the room maybe to check an IV and tried to be as quiet as possible. And they were lightly sleeping and woke up, you know, almost startled that I was standing right next to their bed. So it can really be a challenge, but I think this study proves how critically important that is and how we really need to think about, you know, what orders are being implemented and how we can best promote sleep. Is there another hand raised, Jenny?
We have 3 still. Next is Marie. Go ahead, Marie.
No, I actually, I did not have my hand raised. I apologize.
Oh, okay.
Pardon me.
That's okay. Next will be Donna.
Hi, excellent presentation, Ashley. And I think my question is kind of like a methodological question, but also like whether you would have done anything different. So like, if I'm recalling, you know, your pain levels were lower and your delirium levels were lower. And there's always this balance in studies of having like a sample that you can really find what you're looking for. and also one that represents older adults with multiple comorbidities. So I wonder if you had any thought about that. And particularly, I know Kathy Richards and others are doing a lot of work with dementia and restless leg syndrome. And I think that was one of your exclusions. So I'm just kind of curious whether or not, all of us do studies and then say, maybe I would have done this differently or that. So if you had any thoughts about some of those issues, and particularly with restless legs syndromes or other multiple comorbidities that may have impacted your sample.
Yeah, thanks for that. That's a good question. I think that further, like actually like observing and seeing the patients rather than just focusing on the objective measure, I think that would provide maybe a little bit more feedback, and you could observe if there's disruptions or how many times they got out of bed at night, and getting that subjective data in addition to that objective data from the motion watch. I think that would be something interesting, and it would give a more concrete like observation of what's actually happening during the night in the hospital.
Thank you very much. Yeah, that's a great example. So maybe some mixed methods next time.
Yeah.
And it looks like Cindy Keith has another question for you, Ashley.
Hi. Okay. So as a dementia consultant, I often have families ask me, I do say that they should exercise as much as they can during the day, some type of exercise. What type did you do for these people? I know you didn't probably do dance therapy or anything like that, but was it just a walking program? And if so, how long? And also, I had, in thinking about all of this, my brain went to, okay, what would I do to help a person with dementia sleep better? And one thing that came into my mind was music. And so that might be somebody thinks that's a good area of study for music being played during sleep. I don't know.
That's a really good question. But since we have Irene on the line, she was the interventionist for the study implementing the promotion of activity and physical activity. So if we could bring back Irene, maybe Irene can comment on that.
Sure, I'd be happy to. I think that what we experienced in these acute care settings played out a little bit differently than maybe what might work in a setting like a nursing home or even a home setting. So in the acute care environment, when we're talking about activity, it was really in the realm of function-focused care goals. So we were working with our patients and families to do daily activities within the hospital setting. A lot of that would be walking if the patient was able to walk, but not even all of our patients were ambulatory. So sometimes an activity goal was being out of bed to the chair, maybe performing some sitting to stand activity, even just simple hygiene, participating in their hygiene, self-feeding. So as we developed activity goals, they were more along those lines. So the maximum level of physical activity would be the equivalent of maybe walks around the hospital unit. But again, not every patient was even able to do that. And in terms of music, I mean, that was definitely something that we would promote as a cognitively stimulating activity during daytime hours. So if we had family caregivers that were visiting and were able to help support that, we would absolutely promote something like that, or reading the newspaper or playing a game. So we were really, again, promoting anything that was function focused for our patients. But it was really, again, this acute care setting. It's less of a, unit-based activity program and more individual to the person and what their physical capability was.
Thanks, Irene.
Yeah, thank you, Irene. I just wanted to mention there's a couple comments in the chat. Ray Brown is saying, thank you, great information. And she's mentioning that her aunt, who's 104, sleeps soundly and wants out of bed to eat and wants dressed and to the activity room every day. And she may be a good example of, increasing activity, and how that impacts her positive outcomes related to sleep. Donna is mentioning that there's a great new program in State College for Cognitive Impairment and IDD called Fit Blink Cardio Drumming with chair exercises. If anybody wants to know about that, you can reach out to Donna, or you can send a message to CGNE and we'll relay that. I was mentioning as Irene, or I was thinking about when Irene was talking, how much this FAM FFC really relates to age-friendly care. And even though, as she's describing some of the activities and the movement that patients that are hospitalized with dementia you've been using in this program, is really in line with setting a goal for them, a daily mobility goal, which is part of age-friendly care. So I think it's fabulous that, that's, as you were talking to Ashley, I had, jotted a note to myself about that some of the physical activity strategies that you were implementing as part of this project really do relate to identifying a daily mobility goal for an older adult and how that is really an essential component to age-friendly care. A couple of other strategies I know I've used in long-term care with older adults that have trouble sleeping is not only using music, but sounds can be really helpful. There's an app called Calm that can be put at the bedside, and it has, people can self-select the type of soothing sound, whether it's from nature, it might be birds, it might be a river, that can help to relax someone. And aromatherapy is another one. Did you find any evidence of that in some of those kinds of strategies as you were, doing a little research in preparation of this study?
A little bit more of the music, like the calming, but I didn't get into too much detail on that. But just to go off of, bounce off of what Irene was saying and what you were just implementing in the hospital, we also follow up with the caregivers and the patients after they get discharged for 6 months. And so the interventionist, like Irene, will follow up, make these goals in the hospital and see how we could encourage or help promote any of these activities and functions, also post-hospitalization. And so that's, encouraging for the family as well, to get that support in these calls.
Absolutely. Always good to get a refresher, a reminder, kind of a check-in, and perhaps some additional educational support. But your findings related to the benefits of physical activity and how that helps to really promote sleep was, I think, pretty important for us to consider. So thank you for that. Any other questions that people have or comments for Ashley?
I have a quick question for you, Ashley. Your hospital sites, were they mostly rural or urban or suburban?
They were a mixture,
Okay.
a mixture of urban and rural, and also like mixture of size too, like small, medium, and large.
Great. Thanks. And we
And I
have
see Marie's, do you see Marie's hand? Okay, great.
Okay, now my hand is up. So I just, to follow up on Janice's good comment about the 4Ms, one of the goals of this intervention is to improve or to enhance delirium abatement. So we look at physical function and physical activity as well as delirium as an important outcome. because they go hand in hand. That's one point I wanted to make. And so the intervention focuses not just on physical activity, but cognitive stimulation, encouraging families to stay in contact or bringing in videos or messages from home. We provide activity supplies, diversionary supplies, the music that you already described. So it's important to consider, cognition as an important outcome too. And the post-acute follow-up that, we constantly are reminding ourselves is that our patients have dementia and they really need a very structured routine. So part of what Irene and the other nurses have done has been to develop a very structured plan for the person with dementia that's co-developed with the family and the patient that can be implemented at home. And that includes a plan for physical activity, taking walks, being engaged in ADL, preferred activities. It might be raking leaves or helping with household chores or active games, as well as enriching cognitive activities. So it's really important. We've learned that the person with dementia have that very pre-planned and consistent structured plan. And we do that because that's what families tell us they need. In our prior work, families said, we really need to know how to fill the day so that the person isn't sitting in front of the TV. And I think this brings me to really what my point was in response to Donna's question. What do we need to look at in the future? And we need to look at the effect of this kind of intervention on other measures of well-being and health in older people, such as the sleep and nutrition.
Excellent points, Marie. Thank you so much for sharing that. Any other questions or comments for Ashley? I think we have a minute. Well, Ashley, you've given us so many things to think about, and this study is really well done. Congratulations on the publication that will be coming out. Please share that with us so we can share it with others. But congratulations on that. And thank you so much for providing this very worthwhile and interesting seminar, as well as all of the work you're doing to improve care for older adults.